The case is presented by Dr. Selvakumar. He is a professor and head of the department of Madurai Medical College, and I request Dr. Selvakumar to present the topic.
Respected chairpersons, seniors, delegates, and my dear students. You have been called to give anesthesia for a tubectomy. A young lady is laying on the table. You are preparing to give a spinal because she is little obese. At that time, when you are about to give the spinal, the surgeon asks, shall I send the patient in the evening itself? They demand discharge in the evening. So suddenly a question comes to you. After giving spinal, shall I send the patient home on the same day? That is the big question. So in these 20 minutes, let us try to discuss, get the answer for these questions. So the special requirement for daycare surgery, everybody, we are aware. Whatever technique we use, it should minimally interfere with the patient's physiology. Do you have any? And it should offer a quick recovery. And patient should not have severe pain at the end of the procedure. And the morbidities like PONV should be very minimal, and complications should not be there. And surgery also, for selection of daycare surgery, we have to be a little careful. Generally, if you want to enter into the cavities, they are not preferred, except for minor procedures. And there should not be undue bleeding, no much of tissue dissection, and patient should have been able to have oral feeding at the end of the procedure, so that if she is or he is sent home, he should feed himself. And the surgical factors, we have to consider many. What is the duration, what is the severity, whether they need any blood transfusion, and what about the condition of comorbid status, can you stabilize them, and again, is there any surgical indication for stopping the oral feeding in the post-op period? So after considering all these things, you submit the patient for ambulatory anesthesia, and you try to select a technique. And generally we think general anesthesia is little favored because, especially TIVA, we tackle the patients with IV anesthetics, not interfering with them much, or the surgeon's terminology, short GA, so that he comes out quickly and he doesn't have any permanent or extended impact of anesthesia in the post-op period. So generally we consider general anesthesia is ideal for ambulatory procedures. It provides everything. But is there any role of regional anesthesia? Shall we have to eliminate regional anesthesia from ambulatory surgery? No, definitely. Because there are so many advantages of regional. Of course, it provides very dense and selective anesthesia, and patient is conscious, comfortable, he wakes up, he remains conscious at the end of the procedure. The incidence of complications is very less. So why don't we include regional anesthesia in the ambulatory procedures? But there are some questions to be answered, especially neuraxial block. They are known for their unpredictable spread, especially spinal. And either it is a block or spinal or epidural, they extend over the period of surgery. And the most common complication, bladder attenuation, that is urinary retention, and of course the famous PDPH. Because of these fear, we generally hesitate to apply spinal or neuraxial anesthesia in ambulatory procedures. But can you restrict the spread of spinal up to the area what we want? Can you restrict the spinal spread? Do you have any answer? What are all the factors which decide the spread of spinal anesthesia? Still, it is an unanswered question. But to a certain extent, the science has answered now. We are able to restrict the block a little just 10 years before, because we have got some more techniques, some more armamentarium, some more equipment in our armamentarium. the best way, the traditional way to restrict the block is give a low dose with a hyperbaric spinal, and you manipulate the position of the table so that the spread doesn't occur to the cephalad portion. And using a low dose spinal, I know my colleague, he is using just 0.3 to 0.4 ml of bupivacaine, hyperbaric bupivacaine, for diabetic wound debridements. You know that diabetic wound debridement patients would have had all kinds of complications. So he just uses 0.3 ml, keeps the patient on the lateral position, and he deals with them in a very effective way without much hemodynamic instability. So the low dose spinal, up to 1.5 milligram they have used, and they claim if you use this kind of dose, even motor block is not there, only sensory and autonomic blockade will be there. So that kind of low dose can be used, but generally we use 5 milligram, 1 ml. 1 ml we consider as low dose. That can be tried. Then what about unilateral spinal? So this point I used to wonder. This is the MRI image of a lumbar spine. You can see the dimension of the spinal cord with the CSF. With this dimension, suppose if you are entering through the posterior part into the thecal sac and deposit 1 ml or 1.5 ml, can you make the drug to spread just into the hemi part of the spinal cord? Is it possible? Just 1.5 centimeter diameter thecal sac. Can you restrict your drug into the half of the spinal cord? It's almost impossible. But still, clinically, the shape of the spinal, the vertebral column, the hyperbaricity of the spinal, still it's possible to restrict the block, at least the sensory block, to majority of one part of the body, leaving the motor block without there on the other part of the body. The block will be little patchy, but it cannot get restricted to completely to one side. The other side will also get blocked, but less of motor block and less of autonomic blockade. This is possible, but the question comes here is, how long you have to wait to get a unilateral block? That is fixation of the drugs. This is highly questionable. So they say up to 10 minutes you have to wait for the drug to get fixed so that further motor block will not occur. But to get a complete sensory and autonomic blockade, get fixed, it takes 30 to 40 minutes for the drug to fix the autonomic blockade. So you cannot, of course, you cannot make the person in that position for 30 minutes before surgery. And that becomes a practical thing. But even then, you can restrict the block by, if the time permits, you can wait to an extended period of at least 10 to 15 minutes so that you can restrict the block. Then saddle block. This has been there for since 50, 60 years. So many people we used to give saddle block, ask the patient to sit, give the spinal in sitting posture, definitely in a lower dose, and maintain that sitting posture for 5 to 10 minutes so that you block the area of this saddle area for especially bottom surgeries. So as I said earlier, even 1.5 milligram with 1.5 milligram of heavy bupivacaine, they have tried and they are able to get a true saddle block. But here now our aim is not only restrict the block to saddle area, but to decrease the incidence of bladder atony and also extended recovery. This recovery has to be short in ambulatory anesthesia so that patient can be sent home in the evening. So restricting the dose, providing a saddle block or attempting a unilateral block can be an answer so that you can include spinal anesthesia in the regional anesthesia armamentarium for ambulatory purpose. You know very well. So you keep on increase the dose, it becomes the low dose spinal, medium dosage and high dose. Then the adding to the list of techniques, the continuous spinal. Of course, I haven't given a continuous spinal, but theoretically this is possible. Once upon a time, when continuous spinal was condemned because of the incidence of TNS in the continuous spinal cases, they postulated you are putting a catheter into the thecal space and you are giving the drug again and again through the catheter, and the drug gets exposed to the same nerve root again and again. So in one shot technique, the drug spreads in the CSF and affects all the nerve roots. Here, you are giving the drug and the drug is delivered to the same nerve root again through the catheter. So those nerve roots, because of higher exposure, they developed TNS. So continuous spinal techniques have got the possibility of developing TNS in a higher incidence. That's what it was postulated. Now, with the availability of better drugs, and they are trying to use isobaric spinal in continuous techniques. 0.5 ml increments, you give isobaric bupivacaine or ropivacaine so that this problem of TNS doesn't arise. The only problem is catheterization, a fine catheter through a spinal needle. So they are available now. With better availability of these fine catheters, it should be possible in ambulatory surgery. The next problem is the urinary retention and extended duration. Of course, that can be tackled with whatever I have mentioned. You reduce the dose. You try to use the drug which is short-acting. Once upon a time, I hope the seniors will agree, this lignocaine, it was a blessing for us. We could match so many short surgeries with lignocaine spinal. Even for cesarean, I still consider lignocaine is the best drug because most of the surgeons are very fast. They finish the cesarean within 1 hour and your lignocaine spinal matches it. And by the time they get shifted to the post-op ward, I'm not talking about a corporate institute where post-operative analgesia is given by so many advanced gadgets, somebody is there. But in a place where you shift the patient to the room or a high dependency unit where the monitoring is not up to the mark, that kind of places in rural setup, lignocaine matches the surgical duration beautifully. And in the post-op period, even with minimal monitoring, they come out very nicely. But bupivacaine, it has got an extended duration. Somebody has to be there. So many fatalities for so many morbidities have occurred because of lack of monitoring. So this short-acting lignocaine, after it has gone out, I think it is prematurely sent out, or rather to say, ejected out. So I still feel sorry for not using lignocaine, because we have used in our time thousands of cases of lignocaine. I have yet to see a TNS cases. Probably I haven't monitored or not, I don't know. But our patients never complain any problem with the lignocaine. The seniors should expand on this. Anyhow, try to use chloroprocaine now, and other techniques like epispinal. You can give a low dose, back up with the catheter, so that if spinal wears off, you can top up with epidural. And segmental spinal, I'm not the one who propagates segmental spinal into the thoracic area, but people have started using it. I don't know, in another 10 years, it will become an established technique, but still I am worried to put a needle in the thoracic area. I'm not for it. Then tackling the PDPH, of course, everybody know, using a fine needle will definitely decrease the incidence. Of course, I have slowly started using from 20 gauge when I started learning spinal. 20 gauge was there, metal needle. 22 was finer needle only for assistant professors. Then slowly graduated to other fine needles. Now I am using 27 rarely, 26 regularly. And the one problem with the finer needle is, the right side is a finer needle. I have injected betadine through a finer needle. You can see the spread of drug. The drug gets spread in a wider fashion. So apart from the technical difficulty of finer needles, whether the spread will be high in finer needle or not. Searching through the literature, they say the initial spread may be high like this, but ultimately the final level achieved will be the same whether you use a bigger needle or finer needle with the same dose. So you need not worry. But the only thing is, When I started using the 27 gauge first, that's what happened. After spinal, when I have seen the needle, it was like this. Because during my DA days, I was taught like that at Dublin. You are not supposed to touch the shaft of the needle. So only the hub we should hold. We have learned so with the difficulty how to hold the hub and then without bending the needle how to enter through the interspinal space. But we have learned. We are not supposed to touch the needle. So with finer needles, it's very difficult without holding the shaft. It's very difficult to negotiate through the tough skin or ligament. So at the end, that's what I got. But slowly, now, I have become a little better. And with the pencil point needles, of course, theoretically, we read a lot about pencil point needles. Yes, I have also started using. Only thing is, it's very difficult to go through the skin. It's a blunt needle. The tip will be not as sharp as a cutting needle. So just using a pencil point needle through the skin will be very tough, especially at least in cesarean it will be easy, a soft skin. In older age and all, it's very, very difficult. So you have to introduce a needle, and introduce a needle comes with that. So after putting the introducer needle, you cannot negotiate the needle again. The path of the needle has to be as an introducer needle only. So if you want to redirect the needle, you have to take out the introducer, again you have to put it. So you need a little expertise in putting a pencil point needle. Otherwise it works. So then generally we advise a strict bed rest, additional fluid intake, lot of fluid intake, and epidural morphine, and these drugs prevent the occurrence of PDPH if you are administered well in advance. But literature say these roles are debatable. They say even with bed rest or without bed rest, the same kind of patients will develop PDPH, whether you strictly enforce this technique or not. Likewise, and now they advise, suppose if you happen to accidentally enter into the thecal space with a wider bore needle, immediately put a catheter, keep the catheter for 40 hours, so that it stimulates inflammatory response in the dural structure. So that this inflammatory response, once you take out the catheter, this will seal the hole so that the PDPH incidence will be less. So like that, PDPH and bladder atony can be tackled to a certain extent, and with these kind of techniques, still you can refine yourself. You need not worry much about the extended duration or extended hemodynamic instability or PDPH or bladder atony. You can select spinal for ambulatory surgery. Then talking about the facial plane blocks, definitely they have a role, especially an adjuvant to general anesthesia and to provide post-op analgesia. Then nerve blocks. Can I give a nerve block and send the patient home without being recovered completely? They don't advise. So especially in Indian setup, you put a proper splint and take care of the paralyzed limb. Only when you are sure you can send. Otherwise, a full motor block recovery is a must before you discharge the patient. And of course, if you are trying for a supraclavicular block, you should rule out the dangerous complication, pneumothorax, and then discharge home. And of course, the entry of ultrasound has reduced the risk of these kind of blocks so that you can reduce the dosage, cut down the duration, and increase the success rate, reduce the complications. So many advantages of ultrasound guided. Then coming to the continuous perineural blocks. In Western countries, they advise to put a perineural catheter and send home the patient with the perineural catheter in situ so that they can top up their post-op analgesic drugs. I doubt whether they can be applied in, these are all the gadgets. Now this Celastic pump is available everywhere. You can use it for epidural pain relief or for continuous pain relief. They are not that costly, around 2,000 rupees. You can use it very well. And for axillary blocks, we used to put a Venflon itself, a venous cannula, just identifying the axillary artery. Very close to the axillary artery, because we had put the venous cannula, take out the stylet, and we kept the cannula and used as a continuous infusion of drugs. But whether they can be sent home saying that you can top up yourself is a $1 million question, just like this question. So additives can also be added in any kind of block so that we get especially the harmless drug like dexamethasone. So then BS block is very ideal. I have used in many cases, provided you understand the nuances of BS block and a dependable tourniquet, you can very well give a IVRA for this kind of block. So summarizing this, so the anesthetic requirement and selection of cases is little different from the conventional surgery. Sedation, TIVA is undoubtedly better, and region anesthesia has also got a definite role, especially spinal. So if you understand and if you slightly modify your technique, and anesthetic uses his knowledge of how to cut short the spread, how to cut short the duration, then definitely region anesthesia will be applied, can be applied, and definitely applied in ambulatory anesthesia. Thank you for the wonderful chances. ISA Mysore, thank you.